So let's move on to our thyroid gland. And if we look at the thyroid gland, which is one of the glands of the endocrine system, this gland will be located directly inferior to our larynx, wrapping around the trachea, or wrapping around the windpipe, as the trachea is commonly referred to as. The mineral that's most commonly associated with thyroid malfunction is going to be iodine. And that's because the two primary hormones of the thyroid gland, T3 and T4, which are thyroxine and triiodothyronine, are going to rely on this mineral to have proper function. Now, we here in a developed country have iodized table salt. And that iodized table salt, which contains sodium iodide in it, contains more than enough iodine that we would need for our diet. So generally speaking, we never suffer from iodine deficiencies. So the thyroid gland makes thyroid hormone. And I'd mentioned that there's two kinds of thyroid hormone. We have T3 and T4. Both T3 and T4, both kinds of our thyroid hormone, will regulate our metabolism. You can, if you're suffering from a lack of T3 and T4, occasionally your basal metabolic rate can slow down. Individuals that have hypothyroidism or don't have enough T3 and T4 will oftentimes have excessive weight gain as a side effect of that. And there are multiple mechanisms at play for that excessive weight gain. That can occur because of the decreased metabolism causing increased adipose production. Also, decreased levels of T3 and T4 cause us to retain more fluid in our interstitial space. So in addition to depositing more adipose, individuals that have hypothyroidism are more likely to carry excess liquid or have extra water on their bodies. Another primary hormone of the thyroid gland is calcitonin. And as that name, calcitonin, implies, it is going to regulate calcium levels in our bodies. Here is a common misconception. And this isn't a common student misconception. This is a common A and P instructor misconception, particularly at the high school level. Many A and P instructors, anatomy and physiology instructors, will incorrectly teach that calcitonin causes osteoblasts to be more active. What does an osteoblast do? Osteo is a prefix that means bone. So it's a cell type of the bone. What about blast? What does that suffix mean for naming a cell? We have osteoblast, chondroblast, fibroblasts. Blast means to build. So an osteoblast is a cell type that builds up the bones and makes them thicker. That's the incorrect misnomer that many A&P instructors have. Calcitonin actually inhibits osteoclast activity. An osteoclast is a cell that dissolves the bones to put more calcium in the blood. So if we have too much calcium in our bloodstream, we do not want to start dissolving our bones and add more calcium to the bloodstream. So to inhibit that process, our thyroid gland releases calcitonin. Calcitonin makes the osteoclasts slow down so that we stop dissolving our bones as quickly and stop adding as much calcium to the bloodstream because, hey, we already have too much calcium in our bloodstream. Any questions about calcitonin? Already? So let's talk about some abnormalities of the thyroid gland. We could have a goiter of the thyroid gland, and that's just an enlargement of the thyroid gland that's primarily linked to a lack of iodine in the diet. What hormone relies on iodine from the thyroid gland? Think back to 2 slides ago, or a slide ago. What hormone needs iodine from the thyroid gland? Or hormones? Not necessarily growth hormones. They help to make our metabolism be faster. It'll be the T3 and T4. Both T3 and T4 rely on iodine. So if we don't have enough iodine in our diet, our thyroid gland enlarges because it's trying really, really hard to make T3 and T4, but it doesn't have enough raw ingredients to make that T3 and T4. So let's say somebody has low levels of T3 and T4. They have low levels of thyroid hormone. That is known as hypothyroidism. Low levels of T3 and T4. And there's two primary forms of hypothyroidism. There's congenital hypothyroidism. This is somebody who's born with low levels of T3 and T4. If someone's born with those low levels of T3 and T4, and that's caught early enough, then it'll be just fine. If they are supplemented with T3 and T4 within the first 2 months of life, they'll be just fine. If they go longer than 2 months after birth without this condition being caught, many times they'll suffer from cretinism. They'll have some cognitive developments or cognitive delays associated with the lack of T3 and T4. They'll also have a lack of height added to their bodies. They'll be very short and very stocky as well. So that's for individuals that are born with a lack of T3 and T4. Other times, your body, as you age, can go from having enough T3 and T4 to all of a sudden, let's say you hit your midlife crisis. You hit 40 or you hit 50, and all of a sudden you start not making as much T3 and T4. That's going to be a lack of thyroid hormone as an adult. That is known as myxedema. Individuals that have myxedema have that decreasing of their metabolism. Their metabolic rate starts to decrease. And as their metabolism decreases, they experience lots of lethargy. It's just tough to move. They just don't have a lot of energy. They're also going to experience lots of weight gain. They'll have thinning of the hair. And because their metabolism is slowing down, they aren't generating as much heat. So they have lots of cold intolerance. And, as I mentioned before, one of the symptoms of hypothyroidism is retaining fluid on your body. So because that individual is retaining lots of fluid on their bodies, they'll have very puffy skin that's thickened. On the other end of the spectrum, we have hyperthyroidism. So this is going to be too much T3 and T4, too many thyroid hormones in the bloodstream. And there are two things that can cause this. We can have an exothalamic goiter. So this is going to be the thyroid gland enlarging in response to chronic stimulation from the anterior pituitary gland. That anterior pituitary gland is going to release lots of TSH. And as we have lots and lots of TSH, your thyroid stimulating hormone, causing the thyroid to grow larger, that individual will have an elevated metabolism. So they'll have lots of hyperactivity associated with this condition. They'll also have insomnia. It's hard to fall asleep when your body's constantly burning through excess energy. Also, there'll be a protrusion of the eye. And this is kind of an uncommon term, protrusion. Do any of you ladies know what protrusion means? It's not used very often anymore. It can mean to protrude. What does protrude mean? A synonym for protrude is sticks out or stick out. So individuals that have hyperthyroidism or this exothalamic goiters will oftentimes have their eyeballs stick out, or to use more of a colloquial slang term, they have a bug-eyed look as their eyes are sticking out. We could also have a tumor of the thyroid gland. So we could just have the cells of the thyroid gland reproducing out of control, making too many T3 and T4 molecules. So here's somebody who's suffering from a lack of iodine in their diet. They have a goiter of their thyroid gland. And to compensate for that lack of iodine, the thyroid gland is growing larger. Here's an individual who was born with a lack of T3 and T4. This is somebody who is suffering from congenital hypothyroidism. And thankfully, this individual is young enough that they probably received enough treatment that they were relatively okay. And then here is an individual who has protrusion of one of their eyes because they have an exophthalmic goiter. Directly connected to the thyroid gland, we also have the parathyroid glands. And these parathyroids are going to be located posterior to the thyroid gland. They're connected to the backside of the thyroid gland. Years ago, when patients would have a thyroidectomy, they would have their thyroid gland removed, many times the physician or the surgeon would unknowingly remove the parathyroid gland. And while the physician would unknowingly remove the parathyroid gland, that patient would lose the ability to make parathyroid hormone and would die very shortly afterwards, because parathyroid hormone is essential for regulating blood calcium levels. More specifically, PTH, parathyroid hormone, causes us to increase blood calcium levels. It causes calcium levels to go up in our bodies. And it causes calcium levels to go up in our bodies, in our bloodstream, by causing us to dissolve our bones or break down our bones. What is the name of a bone-dissolving cell? What was that, Ashley? Not just class. For bones specifically? There you go, osteoclast. So parathyroid hormone stimulates the osteoclast activity. And just to review from a little bit ago, a bone building cell, or a cell that builds something, has what suffix? Blast. Well done, Ashley. So parathyroid hormone causes us to dissolve our bones to increase our blood calcium levels. It also causes us to absorb more calcium from the filtrate in the kidneys. In other words, parathyroid hormone makes us urinate out less calcium and keep more calcium in the bloodstream. So if I have too much blood calcium, my blood calcium levels are too high, I will release calcitonin from the thyroid gland. The calcitonin goes to the bones and it inhibits osteoclast activity. And by inhibiting that osteoclast activity, I slow down the rate that I'm dissolving my bones and make the bones absorb more calcium, and blood calcium levels go down in our blood because I stop releasing calcium into the blood from the bones. On the other hand, with low blood calcium levels, those little tiny parathyroids, there's 4 of them, will release parathyroid hormone, which travels to the bone and to the kidneys and to the intestinal tract, and that causes us to dissolve our bones to release more calcium. It causes us to reabsorb calcium from the filtrate in the kidneys, and it causes us to have vitamin D travel to the intestinal tract so that we can then absorb more calcium from the food that we've eaten. Think back to when we talked about vitamins and nutrition in this class. In order to absorb calcium from our digestive tract, we need to have it paired with vitamin D. So think of vitamin D fortified milk or Viactive calcium supplements. Viactive calcium supplements always have, well, in addition to a wonderful chocolatey taste, they also have vitamin D. So, class, concept check. Which 2 hormones work opposite of each other to regulate blood calcium levels? We have T3 and T4, parathyroid hormone and T4, calcitonin and T3, or calcitonin and parathyroid hormone. Which hormones have antagonistic effects or opposite effects on blood calcium levels? So we have 1 for D. If we flip back a slide, we can see that we have calcitonin and parathyroid hormone both responding to either high or low blood calcium levels. The correct answer for this slide is D. Calcitonin and parathyroid hormone work opposite of each other to regulate blood calcium levels. We also have some adrenal glands. These adrenal glands are going to sit on top of the kidneys, or on the superior margin of our kidneys. And as we look at these adrenal glands, we can really describe them as a twofer. They're two in one, so to speak. We have the outer portion and the inner portion. The outer portion goes around the circumference of the gland and is called the adrenal cortex. And to keep these terms straight in my head, I like to think of medulla for middle. They both start with an M. The adrenal medulla is in the middle of the adrenal gland. And then the adrenal cortex goes around the circumference, or the outside of the adrenal glands. The adrenal medulla is going to have innervation or direct control from our nervous system. And the adrenal cortex is going to respond to that ACTH that I mentioned earlier, the adrenal corticotropic releasing hormone, or adrenal corticotropic hormone. And if we look at the histology of our adrenal glands, we can see that between the cortex and the medulla, there's very different tissue types in these glands. So here's the human kidney. And then directly on top of the kidney, we have the adrenal gland. They look like little pyramids or little triangles on top of the kidney. And if I zoom in on this adrenal gland, the tissue on the outside is very different from the tissue on the inside. The adrenal cortex is differentiated from the adrenal medulla. More specifically, the adrenal cortex is going to have many repeating, elongated columnar structures, whereas the adrenal medulla is going to have repeating circular structures in the tissues. So let's first focus on that medulla. It's on the inside, or the middle of the adrenal gland. And when we stimulate the adrenal medulla, we are going to cause that gland to release two hormones from that activate or regulate our sympathetic nervous system. Those hormones will regulate the fight or flight response from the sympathetic branch of the autonomic nervous system. More specifically, those hormones are epinephrine and norepinephrine. Those are more of the international names. The Americanized names are adrenaline and noradrenaline. And that took me an embarrassingly long time to figure out. Epinephrine is exactly the same thing as adrenaline.
And that's the EpiPen, right?
Exactly. So here in America, what are EpiPens filled with? They're filled with adrenaline. But in Europe, what are EpiPens filled with? They're filled with epinephrine.
They're the same thing.
Same chemical.
Okay.
Now, if we look at this cortex, this adrenal cortex is going to be on the outside of the adrenal gland, and it responds to what hormone? What hormone of the anterior pituitary gland stimulates the adrenal cortex to release cortisol? It has a big name, kind of a mouthful. I'll accept the full name or the abbreviation. What hormone stimulates the adrenal cortex? The one I'm fishing for is ACTH, adrenal corticotropic hormone. Now, if we look at our adrenal cortex, it's going to release two primary kinds of hormones. It's going to release glucocorticoids and glucomineroids. Our glucocorticoids are going to regulate our macromolecule metabolism. So regulate our metabolism of proteins, carbs, and lipids or fats. If we have elevated cortisol levels, we downregulate carbohydrate synthesis or metabolism and upregulate protein and fat metabolism in our bodies. Another response from our glucocorticoids is to decrease or suppress the inflammatory response in our bodies. So if we look at cortisol, cortisol is primarily going to have an effect on the metabolism of the macromolecules, and then cortisone, which is chemically very similar but distinct from cortisol, will primarily be given to regulate the inflammatory response. So think of the patient that has the pain in their hip or the pain in their knee or their ankle. They can go in and receive a cortisone shot to relieve the inflammation and temporarily, for a couple weeks, reduce the amount of pain in that joint. We also have the mineral corticoids. These mineral corticoids are going to regulate mineral or salt balance in our bodies. The two minerals that we are primarily going to affect are going to be potassium ions and sodium ions. And the hormone that does that is aldosterone. Aldosterone causes us to reabsorb more sodium in our bodies. So if somebody has low blood pressure, they can release aldosterone and their blood becomes saltier, or they have more sodium in their blood. And that causes more water to get sucked into their bloodstream and their blood pressure to go back up again. So, in summary, here's our adrenal glands. It's a twofer. We have the adrenal medulla that's going to be activated by the sympathetic branch of the nervous system. And then the adrenal medulla releases epinephrine and norepinephrine, the hormones associated with being scared. And then those hormones are going to travel into the bloodstream and help cause our stressful responses. So we're going to have our heartbeat go up, we're going to have our blood pressure increase, we'll have dilation of our pupils. So in really stressful situations, our pupils actually open up to let more light in so we can better see whatever it is that's stressing us out. And we'll also have ACTH coming from the anterior pituitary gland. That ACTH travels to the outside of the cortex of the adrenal gland, the adrenal cortex, and causes cortisol and aldosterone release, depending on what specific hormones we're interacting with. If we have those glucocorticoids released, we are going to upregulate protein and fat metabolism. So we'll preferentially break down our proteins and our fats, and then preferentially not break down glucose. We'll also downregulate the inflammatory response. If we have the mineral corticoids released, the aldosterone, we will have an effect on our blood mineral content. We'll absorb more sodium into our bloodstream. And there's some diseases that are related to the adrenal glands. I know a young man who almost died from this disease, Addison's disease. Addison's disease is a classic disease that everyone talks about when they introduce the endocrine system, but it's so incredibly rare that most people forget about it because they're never exposed to a patient that has it. And I remember I was kicking myself in the pants because this young man that I knew had all of these classic symptoms of Addison's disease, but I never put the pieces together until it was almost too late. Addison's disease is characterized by hyposecretion of glucocorticoids. In other words, these individuals have very, very low levels of aldosterone in their body, the primary glucocorticoid. And in response to really low aldosterone levels, a couple things are going to happen. First, what mineral does aldosterone make us reabsorb into the bloodstream? What was that, Ashley? Sodium. Very good. So if you don't have enough glucocorticoids, if you don't have enough aldosterone, you'll have very low blood sodium levels. And if you have low blood sodium, you have really low blood pressure. It's really hard for you to keep water in your bloodstream. So individuals that have Addison's disease are very prone to passing out because they have excessively low blood sodium and excessively low blood pressures. A hormone that's also released from the anterior pituitary gland is melanocyte stimulating hormone. And this hormone is chemically very similar to ACTH. So if we're releasing lots of ACTH into the bloodstream, we'll also, as a side effect, release lots of melanocyte stimulating hormone. And these individuals will have a bronzing of the skin. They will be abnormally tan, even though they aren't spending a lot of time in the sun or in a tanning booth. And particularly, if you're looking at a Caucasian patient, the big red flag that they have Addison's disease is that their gum lines become tan. Part of their body that is never exposed to the sun ever becomes tan. So if you look at their armpits or other parts of the body that generally never have sun exposure, and if those parts of the body have a good tan, you know that they have Addison's disease. And that's only for Caucasians. The individuals of African descent will oftentimes have a tan gum line, and that's not indicative of Addison's disease.
Have you heard it in canines?
Addison's in canines? I'm sure it exists.
They had it tested on their husky.
Oh, sounds expensive. Yeah. Another disease of the adrenal gland is Cushing's syndrome. Cushing's syndrome is associated with hypersecretion of glucocorticoids. So somebody who has Cushing's syndrome is physiologically constantly stressed out. And there can be a couple things that can mimic Cushing's syndrome. If you are working with an individual that just has a propensity to always be stressed out, they're a glass half empty kind of person, and they're always finding the bad things in life and being stressed out about those bad things, they can elevate their glucocorticoid level artificially and develop Cushing's-like syndromes. Individuals that have too many glucocorticoids, so too much cortisol and too much cortisone in their bloodstream, so too many stress hormones, are going to have weight gain characterized by the preferential ignoring of glucose metabolism, and instead they'll preferentially break down their proteins. And as they're preferentially breaking down proteins as an energy source, they lose muscle mass, and their basal metabolic rate starts to drop down. Another symptom of Cushing syndrome is that adipose tissue travels from the appendages and is preferentially deposited in the trunk of the body as well. And then those individuals will also have the characteristic high blood pressure, the characteristic elevated heart rate, and all the other symptoms that are associated with chronically activating your sympathetic nervous system. So, class, I have a question for you. Concept check. The adrenal blankety-blank is controlled by the nervous system, and the adrenal blankety-blank is controlled by hormonal stimulus. So what part of the adrenal gland is controlled by the nervous system? What part of the adrenal gland is controlled by that hormone released from the anterior pituitary gland? That hormone is ACTH, adrenocorticotropic releasing hormone. So we have a D. The adrenal medulla is controlled by the nervous system. The adrenal cortex is controlled by the endocrine system or hormonal stimulus. That is correct. D is the right answer. And that's all we have time for right now. If you have any questions for me, you can feel free to ask me outside a lecture.